Hello, I'm Dr. Anthony Wheeler, and I'm telling you everything that you need to know about pathology. Would you say this urine collection sample resembles a certain drink? Coca-Cola maybe? Yes, we'll be talking about this and much more in this presentation on nephritic syndrome pathology. So you future kidney docs, listen close. All of this is covered in your book, Medical School Pathology and Step 1 Review. You can scan the QR code to get to the updated material. Now, nephritic syndrome. Yes, nephritic syndrome. These are characterized by bleeding. Take a look at this image. We can see purpura that is present in a patient with nephritic syndrome. Nephritic syndromes show glomerular inflammation and bleeding. Symptoms of nephritic syndrome includes limited proteinuria, oliguria and azotemia, salt retention with periorbital edema, right, swelling around the eyes, hypertension, red blood cell casts, and dysmorphic red blood cells in the urine. And what is that limited proteinuria? That is less than 5 grams per day. Now, the histology of nephritic syndrome shows inflamed glomeruli. Complement is activated by immune complex deposition. And the neutrophils mediate the damage and are drawn to C5a. Nephritic syndromes that you must know include PSGN, right? Probably the most important one, Post-streptococcal Glomerulonephritis, as well as rapidly progressive glomerulonephritis, IgA nephropathy, and Alport syndrome. Just to make sure you heard me, Alport syndrome. Can you hear me? Alport syndrome. If you can hear me, it's highly likely that you don't have Alport syndrome, right? Because patients with Alport syndrome have a tendency to be deaf. Here's an image showcasing the microscopy from a patient with nephritic syndrome. They have hematuria. So what you're actually looking at is microscopy of red blood cells that were found in the urine. Post-streptococcal glomerulonephritis. Very important to know. In this condition, which is a type of nephritic syndrome, there's an actual development of glomerulonephritis, which follows a pharyngeal or skin infection with a group A streptococcal bacteria. To the right here, you can see a urine sample with clear, gross hematuria, right? This buzzword, cola-colored urine. Post-streptococcal glomerulonephritis occurs with nephritogenic strains that carry the M protein virulence factor. Post-streptococcal glomerulonephritis can also occur after infection with non-streptococcal organisms. PSGN presents 2 to 3 weeks after an infection as cola-colored urine, right, due to the hematuria, oliguria, hypertension, and periorbital edema. Post-streptococcal glomerulonephritis normally affects children, but it can also occur in adults. And it's important to know that PSGN is mediated by immune complex deposition with granular immunofluorescence. Here we can see the histology from a patient with post-streptococcal glomerulonephritis showing a hypercellular inflamed glomeruli. The electron microscopy of PSGN shows subepithelial humps. And the treatment is supportive care. The treatment of PSGN is supportive care. Unfortunately, renal failure is a potential complication of post-streptococcal glomerulonephritis, and this develops in children about 1% of the time. A small percentage of individuals with post-streptococcal glomerulonephritis experience rapidly progressing glomerulonephritis. Here we have imaging showing diffuse proliferative glomerulonephritis involving approximately 40%, showcasing those half moons, and significant tubulus atrophy and interstitial fibrosis with inflammation. Now let's talk a bit about rapidly progressive glomerulonephritis because it's an important condition to be aware of. In RPGN, which is a type of renal pathology, the issue develops from nephritic syndrome within weeks or months. The histology of RPGN shows macrophages and fibrin crescents in the Bowman space of glomeruli. It's important to note where that occurs. The Bowman space of glomeruli. Immunofluorescence and the clinical picture aid in determining the cause. Here we can see imaging of rapidly progressive glomerulonephritis. Note the crescentic glomerulonephritis in a patient with MPO ANCA positive rapidly progressive glomerulonephritis. And here we have the renal biopsy. We know that because we can see the glomeruli in A at least, from a patient who's 60 years old with posse immune extracapillary proliferative glomerulonephritis due to IgG kappa multiple myeloma. A was before treatment and B is after treatment with bortezomib. Now let's talk about IgA nephropathy. IgA nephropathy is also known as Berger disease. To the right here, we can see a renal biopsy showing light chain cast nephropathy in a patient with an IgA lambda paraprotein. Note the deposits within the cast. The most prevalent nephropathy in the world is IgA immune complex deposition in the mesangium of the glomeruli. We can see IgA nephropathy in this image here, and note the immunostains actually staining the IgA in the glomerulus of this patient with Hinoch-Schlolen nephritis. IgA nephropathy typically presents in childhood as episodic, gross, or microscopic hematuria with red blood cell casts. IgA nephropathy typically follows a mucosal infections, right? So look out for that. For example, a patient with gastroenteritis, they might obtain IgA nephropathy shortly after that condition. During mucosal infection, IgA production rises. It's important to remember that on immunofluorescence of IgA nephropathy, it's the mesangium IgA immune complex deposition that is visible. And unfortunately, IgA nephropathy can gradually lead to renal failure. Here we have various images showcasing a subepidermal blister in the skin, and then in panel B, polymorphonuclear leukocytes, and then C, linear deposition of immunoglobulin A along the basement membrane of the skin, right? So this is just a reminder that IgA deposition can occur in other systems, so don't forget about that. Now, Alport syndrome. Alport syndrome is an inherited defect in type 4 collagen. Do you remember the mode of inheritance? Is it X-linked, autosomal recessive, dominant, via the mitochondria? What is it? You're going to be asked probably. If you don't know, don't worry, I'll tell you. But first, let's look at this kidney biopsy from a patient with Alport syndrome. Interesting. Can you see the glomeruli? Now, Alport syndrome, importantly, is for the most part, at least for your purposes, remember, an X-linked disorder that most often affects males. Now, I know there's that one person out there, well, there's the autosomal recessive form. I'm not talking about that. I'm getting you ready for tests. I'm telling you what you need to know. You need to know that Alport syndrome, for your purposes, is an X-linked disorder that most often affects males. It's also important to remember that this condition leads to thinning and splitting of the glomerular basement membrane. Symptoms of Alport syndrome include isolated hematuria, sensory hearing loss, and even ocular abnormalities. And that is why it shows up on a lot of clinical vignettes, right? Because it has so many unique features, and they can test it whether you know your systems and the pathology. Test takers love talking about Alport syndrome. It's super rare, which means it's going to be common on your examinations. And with that, I'd like to congratulate you on finishing yet another very important presentation. You're making great strides to ensure your success. Let me know if you have any questions, any comments, any concerns. Keep up the good work. Keep making me proud. And I'll see you next time.